time, we'll go to the session proper. So today we have the topic pharmacogenomics in pediatric care to look at. So this aspect of pharmacogenomics, as we can tell from the topic, is a game changer in personalized medicine for children. So before I introduce the speaker and start the session, I would like to quickly state the house rules. Please kindly ensure that your mic is always on mute when you are not speaking, so we can avoid distractions. And you can turn on your camera if possible, so you can show the speaker that you are attentive. Then always use the chat box for questions and if you have anything to state during the talk. So I'll go straight to introduce the speaker and read his bio. So our speaker for today on the topic pharmacogenomics in pediatric care is no other than Dr. Kazeem Adeola Oshikoya. He's a professor in clinical pediatric pharmacology at the Lagos State University College of Medicine and is an expert in pharmacology, therapeutics, and toxicology. So he's indeed an authority in the field of pediatrics, and I will read his bio now so we can all get to know more about him. So Dr. Kazeem Adeola Oshikoya is a physician scientist and currently a professor in clinical pediatric pharmacology at the Department of Pharmacology, Therapeutics and Toxicology, Lagos State University College of Medicine, Ikeja, Lagos, Nigeria. He had his undergraduate medical education at the University of Lagos in 1996. He's a master in pharmacology. He had his master's in pharmacology at University of Lagos, PhD in pediatric pharmacology at the University of Nottingham, and postdoctoral research fellowship at the Vanderbilt University. His research focuses are complementary and alternative medicines, pharmacoepidemiology and pharmacovigilance, drug metabolism, and pharmacogenomics in children, of course. So over the last 2 decades, he has published extensively in many high-impact peer-reviewed international and local scientific journals. He has over 70 publications to his credit, spanning the field of core pediatrics, medical education in pharmacology, pharmacoepidemiology, complementary and alternative medicines, drug metabolism, and pharmacogenomics. He has won several awards and is a member of several associations and learned societies, both at home and abroad. So he's a recipient of the late Otumba Adeniran Ogunsanya Scholarship for undergraduate study at the College of Medicine, University of Lagos, Nigeria. He's also a recipient of Lagos State Government Foreign Scholarship for postgraduate study in the United Kingdom, a recipient of Travel Scholarship by the organizers of IQM 2011 to attend the 3rd International Conference for Improving Use of Medicines at Antalya, Turkey in November 14 to 18, 2011. He's a recipient of partial scholarship from the International Society for Pharmacoepidemiology to attend the ICPE meeting in Barcelona, Spain. He's a recipient of the IUPHAR Education Bursary Scholarship to attend the EACPT Summer School of Education in Amsterdam, the Netherlands. He's a recipient of Therapeutic Editor Fellowship Training in 2014 in Melbourne, Australia, which enabled to the revised 2014 edition of in HIV and AIDS. To many academic societies in both Nigeria and International Society for Pharmacology and Experimental Therapeutics, International Society for Pharmacoepidemiology, and American Society for Clinical Pharmacology and Therapeutics. So he has been an external examiner to various medical schools in Nigeria during second professional MBBS examinations, including College of Medicine, University of Lagos, Abubakar Tafawa Balewa University, Bauchi, Afe Babalola University, Ekiti, Eco University of Medical Sciences, Lagos, and Obafemi Awolowo University, Ile-Ife. So it is very clear that our speaker is very well suited for our topic today. So I would like us to usher our speaker in with a round of applause. Let's keep the reactions coming. Let's keep the reactions coming. Okay. Dr. Oshikoya, thank you for joining us today. So I would love to hand over the microphone.
Thank you very much, Christabel.
Thank you very much,
sir. I also want to thank Egosa for the invitation. I need to apologize first to have missed the last session where I was supposed to present. I actually missed out the date. I was thinking it's on the 24th, not knowing it was actually earlier than that. So pardon me for that. Can you please share my slide?
Oh, okay.
Oh, certainly. Yeah, I'm on that now. Yeah.
Well, I need to mention at this point that my slide is just going to be a synopsis of what can be done in the field of pediatric care regarding pharmacogenomics. Many of the conditions that pharmacogenomics is relevant in pediatrics is extensive, but I've been able to choose some and highlight some important things and how pharmacogenomics actually play its role there. So I hope I can have the slides on and I can run through everything as soon as possible.
Yeah, almost there now. Okay. Can we see my screen? Can you see my screen?
I can't see your screen just yet.
Okay. How about now?
Still same from my end. Okay. Oh yeah, I can see your screen now.
Okay.
Okay. Okay, yeah. So sorry about the delay.
Okay. Thank you. So as rightly said, I'll be discussing pharmacogenomics in pediatrics care. Next slide, please.
Okay.
Okay. So I'll try to run through it under the following headings. I'll give you a background information about pharmacogenomics. Thereafter, I'll talk about the significance of efficacy and safety in medicine in children. Because when we talk about pharmacogenomics, the major goal is to achieve high drug efficacy in terms of treatment and minimize adverse effects, which relates to safety. Then I shall also inundate you about the current practice globally. That's the use of precision medicine. Precision medicine is not synonymous with pharmacogenomics, but is an aspect of achieving good therapeutic care and minimal adverse effects, putting into consideration so many factors, particularly pharmacogenomics and pharmacogenetics. Then I will illustrate with some spectrum of diseases in pediatrics where precision medicine is required. And if you have to require precision medicine, definitely pharmacogenomics will come into be there. Then we'll look at some of the disease conditions where pharmacogenomics is actually actionable. That is to say that you can actually do genotyping before drug is administered to that condition. Then I give you some various examples of case reports where pharmacogenomics actually play a role in diagnosing some disease conditions as well as managing such conditions. Then I'll wrap everything up by providing you a summary of everything in the conclusion. Next slide, please. So by way of introduction, I'm sure many of us, being that we are in the field of pharmacogenomics, you quite understand what we mean by pharmacogenomics. But I want to assume that there may be some of us who are green on in this field that may want to enrich their knowledge. So I'll start by providing you information about what pharmacogenomics is. It is a branch of pharmacology that relates to the study of genetic factors determining variability in drug response in terms of both efficacy and toxicity. You agree with me that response to treatment will always be in twofold. The response may be to achieve therapeutic efficacy of the drug or to minimize the toxicity of the drug. So pharmacogenomics puts both conditions into considerations. Medications with actionable pharmacogenomics associations are frequently used in children. Therefore, you agree with me that pharmacogenomics guided precision medicine is readily applicable to the pediatric population as it's obtainable in the adult population. The use of pharmacogenomics in pediatric clinical practice is therefore increasing, and this is necessary to guide drug prescribing, that's rational prescribing, has led to increased availability of genetic testing, which is included in the actionable uh, processes, as well as increased prescribing guidelines. So many hospitals globally, they have formulated their own guideline for treating certain conditions based on their genetic relationship. Next slide. Significant variation in the genes encoding drug metabolizing enzymes, as well as transporters, which are the pharmacogenes that are central to pharmacokinetic processes of a drug, have been reported. The impact of genetic variation in pharmacogenes is modified by factors such as age-dependent changes in gene expression, which is ontology. You agree with me that the way the metabolizing enzymes develop in utero and in the neonatal period before getting to older age group, infancy, varies between adult and children. Also, age-dependent, the developmental changes in the activity of metabolizing enzymes such as CYP3A, CYP2C, CYP1A, isoforms, as well as the UGT involving phase 2 metabolism, affect both phase 1 and phase 2 drug metabolism. These enzymes, apart from undergoing developmental changes, they also exhibit polymorphism. Therefore, the response of newborns as well as infants to drug therapy may differ from those of adults. That necessitates us to focus on pediatric care rather than extrapolating from those of adults. Next slide, please. Genotype guided prescribing in pediatrics could prevent adverse drug reactions and improve therapeutic response. Clinical pharmacogenetic implementation guideline, CPIC guideline, are available for many medications commonly prescribed to children. And I'm glad to say I've contributed to the development of some of these guidelines regarding prescription of drugs for individuals that are G6PD deficient. Frequencies of medication prescription and actionable genotypes inform the potential value of pharmacogenetic implementation. Genotypes where a prescribing change may be indicated. That's the meaning of actionable genotyping. That is, your prescription is guided by genotyping to know the kind of polymorphism or metabolizing status an individual is carrying before you prescribe drug. Next slide, please. Now, let's go through efficacy and toxicity in children. As earlier said, pharmacogenomics focuses on improving efficacy of a drug in terms of therapeutic outcome as well as minimizing the toxicity. So it is good for us to have a clear understanding of what efficacy and toxicity are. Drug efficacy occurs when the medication stabilizes, improves, or diminishes a disease state or health condition. Simply, drug efficacy occurs when the desired beneficial outcome happens with the standard dose of a prescribed medication. Drug efficacy is determined by its plasma level at therapeutic level during pharmacokinetic studies. So you administer a drug to an individual. Before you begin to see improvement in the condition, it means the therapeutic level of that drug must have been attained. And to achieve the therapeutic level, the drug must pass through the processes of pharmacokinetics, depending on the route of administration, either orally, intramuscularly, intravenously. So having gone through all this, it is expected that the drug must achieve therapeutic level that will now produce the desired effect. However, the level of the drug varies from individual to individual as a result of variation in the enzymes involved in the entire process of pharmacokinetic. Next slide, please. Drug toxicity can occur if a drug's concentration exceeds a therapeutic range. This may occur secondary to an unintentional or intentional overdose, or because drug accumulates. Toxicity is the state of being nauseous or is described as a drug's ability to poison the body. Both drug efficacy and toxicity are significantly influenced by individual variability in their cytochrome P450 transporters as well as phase 2 metabolizing enzymes. Next slide, please. Now, let's look at precision medicine. Precision medicine sometimes is used interchangeably with personalized medicine. Yes, but there are little differences there, which I'm not really going into. But when we talk of precision medicine, the goal is to achieve personalized medicine, where drugs can be tailored to individuals' need and their genetic makeup. So precision medicine is being practiced both in adults and childhood. It is well established among adults, but is gaining more interest, and that is the basis for our discussion today because it's something that is being applied globally. However, there are some limitations that are affecting the global implementation of precision medicine, which of course it's not within my scope to talk about that. I want to assume everybody knows some of the challenges that are faced in implementing precision medicine. So precision medicine looks at the genetics, environment, and lifestyle of a person in order to select treatment that could work best for them. Now, you could see that it is not solely dependent on the genetic composition of that individual. Apart from presence of genetic variation in relation to drug absorption as well as entire drug metabolism, other factors can influence drug response in individual, and such factors include environment as well as lifestyle of an individual. But genetic plays a dominant role, which of course we cannot overlook. It is an innovative approach to tailoring disease prevention and treatment. His goal is to target the right treatments to the right patient at the right time. And you can see that in the diagram above there, where you have different individuals coming together in a community or a special group, which is pediatrics. And you could see that drugs are tailored to individual use based on the genetic as well as other factors indicated there. And you could see that the two individuals at the bottom of the diagram are showing various responses and reactions to the drugs taken. So precision medicine enables us to actually tailor drugs to individual in pediatrics. Next slide, please. Next slide, please. Hello, next slide. Okay. Now, precision medicine in turn predicts if a patient can tolerate conventional dosing without a sharp increase in the risk of, oh, sorry, I think slide 9 had been mixed. Okay. So we now look at the spectrum of diseases in pediatrics requiring precision medicines. And when I talk about precision medicine, I'm telling you where pharmacogenomics can be applied in their drug therapy. There are so many conditions that precision medicine is being explored in pediatrics. However, I've been able to pick some important areas and illustrate with some specific drugs in those conditions where pharmacogenomics have been able to improve drug therapy leading to precision medicine. One of such field is oncology, cancer treatment. Now, some of the drugs that are used in treating cancer conditions include azathioprine, cis-macabtopurine, and a host of others. Now, this drug is being metabolized by an enzyme called thiopurine S-methyltransferase, simply put as TPMT. This enzyme is central to the metabolism of the very commonly used chemotherapeutic drug, cis-macabtopurine, for treating acute lymphoblastic leukemia. It exists as a monogenic autosomal codominant trait. That's the leukemia we are talking about. Now, the enzyme has a number of loss function alleles, which determines if a patient is normal, intermediate, or low metabolizer. So there is variation in the enzyme. This in turn predicts if a patient can tolerate conventional dosing without a sharp increase in the risk of myelosuppression. One of the adverse effects of cis-macabtopurine is myelosuppression, where the entire cell lines in the bone marrow are completely suppressed, and it could be life-threatening. And this had been seen in some patients after being commenced on the drug for leukemia. So people would now begin to look at what could be the cause, and this was linked to variation in the activity of TPMT in various conditions. These insights have been translated into clinical guidelines. So many hospitals, home and abroad, now have a policy in place, like a treatment protocol, that an individual to be prescribed the cytotoxic drug, such as cis-macabtopurine, definitely that individual must undergo genotyping for them to know if they can prescribe the drug with minimal adverse effect, or they have to tailor the dose to minimize the adverse effect. In many healthcare systems, mandatory TPMT genotyping for children with cancer is required. This is necessary before treating with cis-macabtopurine. Subsequent dose adjustment may be necessary depending on the genotype of that individual. It is now part of their therapeutic protocols. There may not be a national guideline on this or international guideline. And as a matter of fact, it is an international guideline now that for you to prescribe any drug metabolized by TPMT, you have to do the genotyping. I will elaborate more on that when I get to other areas. Next slide, please. Another specialty where it's precision medicine is being implemented is in the treatment of gastrointestinal diseases, such as inflammatory bowel diseases. There are three forms of this disease, including Crohn's disease, ulcerative colitis, and non-specified irritable bowel disease. The mainstay of treatment for inflammatory bowel disease is steroid, but because of the associated adverse effects, individual with this condition, after remission, they tend to switch them to drugs that contains thiopurines, and thiopurines also contains drugs like 6-macabtopurine as well as azathioprine. So thiopurines are recommended as an option for maintenance of steroid-free remission. In children at risk for poor disease outcome, if you feel that the clinical condition of that patient is so bad, you can as well switch to the use of thiopurines. And for reducing the formation of antibodies to biologics, azathioprine, AZA, is a form of thiopurines used for treating irritable bowel disease. Next slide. And the metabolism of azathioprine is similar to the metabolism of 6-macabtopurine. Now, this diagram tells us the pathway for metabolizing azathioprine. Azathioprine is a prodrug, which of course will be converted to 6-macabtopurine. 6-macabtopurine is a metabolite of azathioprine, and 6-macabtopurine itself is still an inactive metabolite and is metabolized through two pathways, through the TPMT as well as AGPRT. Now, the AGPRT will lead to the production of 6-thioguanine. This 6-thioguanine is what produces the therapeutic efficacy of azathioprine as well as 6-macabtopurine. The excess level of 6-thioguanine is also a determinant of the side effect, which is myelotoxicity. Now, if the level of 6-thioguanine is so much, you will achieve a very good treatment outcome. However, the level of myelosuppression is going to increase. Therefore, you have to look at what is happening through the other pathway. Now, the other pathway is metabolism of 6-macabtopurine through the TPMT pathway, which is the enzyme that converts it to 6-methyl-macabtopurine. This does not have any effect on the treatment of leukemia. However, it is a byproduct which eventually may lead to hepatotoxicity if it accumulates. Now, in a situation where an individual is a slow metabolizer, that is, it carries the TPMT as a poor metabolizer, the pathway that will convert 6-macabtopurine to 6-methyl-macabtopurine is going to be slowed. Then you now have accumulation of 6-macabtopurine, which the enzyme HGPRT will now act upon and produce excess of 6-TG because there is accumulation of 6-macabtopurine. However, if an individual is a normal metabolizer, the level of 6-macabtopurine that will be generated will be adequate to be metabolized through the HGPRT pathway to now produce the normal level, therapeutic level of 6-TG. Also, if an individual carrying the TPMT enzyme is a fast metabolizer, then it means there will be fast conversion of 6-macabtopurine to 6-methyl-macabtopurine, leading to hepatotoxicity in fast metabolizer, as well as leading to low level of 6-macabtopurine because majority of it will have been fast metabolized to 6-MMP. Therefore, the amount of 6-macabtopurine that will be available to produce the active component that will treat the patient will be very less, and therefore the 6-TG therapeutic level is not going to be achieved. Next slide, please. So based on what I just discussed, because the fate of cis-mercaptopurine is dependent on the metabolizing status of TPMT. Consequently, it is not mandatory that for you to prescribe either azathioprine or 6-mercaptopurine, you must genotype the TPMT enzyme to know the status of that individual. And you can now prescribe the drug to individuals that are normal metabolizers. So myelosuppression in patients with irritable bowel disease treated with thiopurine is reported more frequently in the Korea. The Asians, they tend to have the enzymes that show more polymorphisms among polymorphism to TPMT. Therefore, this is being well practiced among the Asians, where genotyping for TPMT is mandatory. So in Korea, 31 to 56% are more susceptible to myelosuppression compared to their counterparts in Europe and America. It means that the metabolism of cis-mercaptopurine or azathioprine tend to be very slow, and there is conversion through the other pathway that generates cis-TG. So among the Asians, particularly in Korea, genotyping for TPMT is more practiced. According to a Korean report, 137 patients with irritable bowel disease treated with azathioprine showed a wild type in 130 of them, that is 95%. So when you have the wild type, it means that person is carrying the normal variant. And there are variants of them which could be in form of loss of function, where you have star 1 star 3C, which was found in 4 individuals, then star 1 star 6, which is found in 1 individual, star 1 star 16 in another 1 individual, then you have star 3C in 1. So altogether you have 4 plus 3. Among these 137 people, 7 of them were known to show slow metabolism because of the variant genotype they have. So if they didn't do the genotype and these individuals are prescribed the normal dose of azathioprine or cis-mercaptopurine, they will be at risk of myelosuppression. Next slide, please. Azathioprine dosing guidelines for Asian patients with irritable bowel disease is quite different from what is obtainable globally, as well as European Society for Irritable Bowel Disease. Among the Asian, the dosing of azathioprine is reduced to 1 milligram per kg per day, but universal guideline, that is globally, it is supposed to be 2 to 3 milligram per kg per day, according to Consortium for Pharmacogenomic Implementation. So their guideline states that you should give 2 to 3 milligram per kg per day, whereas in Europe, it is put at 1.5 to 2.5 milligram per day. And that is because majority of population in those areas, they are normal metabolizers. So Nordic hydrolase, which is another enzyme, is a novel thiopurine metabolizing enzyme, a missense variant of which is strongly associated with thiopurine-induced leukopenia. Another side effect that is associated with thiopurine drugs, is azathioprine or cis-mercaptopurine, is leukopenia, where you have the entire white blood cell being low, which is very common among the Asians. Apart from TPMT being genotyped, they have even found out that another enzyme, which is Nordic hydrolase, that is NUDT15, also undergoes polymorphism, and that also is being genotyped before prescribing. So it's not only TPMT that you do genotyping for. If you have to give any of these thiopurine drugs, you have to do NUDT15 genotyping also. Previous studies have reported no evidence in the level of cis TGN levels among those with NUDT15 genotype. Now, it's been shown that myelosuppression is independent of NUDT15 because the level of the active drug that takes care of leukemia or that takes care of irritable bowel disease is known to not change when they do genotyping for NUDT, and such individual with NUDT polymorphism, either poor metabolizers, they do not exhibit myelosuppression, but they exhibit leukopenia. Therefore, both enzymes are necessary and they become actionable. Next slide. A recent study on NUDT15 polymorphisms in 167 Korean patients who were treated with azathioprine reported leukopenia in 16% of them who are normal metabolizers, in 44% who are intermediate metabolizers, and 100% in those who are poor metabolizers. Therefore, NUDT polymorphism was the only factor associated with time to leukemia. So it becomes very necessary that among Asians, these enzymes are genotyped. Next slide. Next slide, please. So I want to illustrate some cases where I have done some work. At Vanderbilt, we try to look at implementation of pharmacogenomics in the care of children with behavioral disorders. Now, the FDA regulates the age group that risperidone can be prescribed. Usually, it is prescribed for individuals, children with behavioral problem, and that's why you see it more used among children with autism, but not for all other attention problem. But there must be behavioral problem that is associated to the primary problem. So we took a look at the reported, we mined cases of adverse effects to risperidone among the pediatric population that were prescribed the drug. And we found out that there were a lot of adverse effects associated with it. So we decided to look at the CYP2D6, which is the major enzyme that metabolizes risperidone. Then we want to link the polymorphism of that enzyme to the reported adverse effect that we observed. And it was found that for the 257 individuals that we genotyped, we were able to group them as poor with intermediate metabolizers, who were just 33 among the population, and those that are normal or ultra rapid metabolizers, who were majority of the population that we saw. Adverse effects of the drug, as observed in the children, were more common in poor and intermediate metabolizers compared to normal and ultra rapid metabolizers. So we could link this by, after putting all other factors that could influence the adverse effect we observe, which include age, sex, race, and the initial doses of the drugs that were given. By the time we use all these parameters as co-founder, we realize that it is only the metabolizing status that are poor and intermediate that pose the risk of adverse effect in the children that we genotype. So children with CYP2D6 who are poor intermediate metabolizer phenotypes are at a greater risk for risperidone adverse effect. And it was suggested that actionable genotyping should be done for prescription of risperidone, since it's the only antipsychotic drug that was recommended for pediatric use compared to all other ones that were used as off-label. And in the protocol of Vanderbilt Children's Hospital, it has been implemented that actionable decision must always be taken for risperidone prescription by doing the genotyping. Next slide, please. In cardiovascular diseases, precision medicine is being achieved also. We all know that warfarin is the most frequent anticoagulant used in pediatrics, and there are so many conditions for which it can be prescribed. Among them is conditions with that are thrombotic events. Also, children with congenital diseases such as mitral stenosis are often treated with warfarin to prevent clot formation. So warfarin is considered as a potentially dangerous medication by the Institute for Safe Practices in the Use of Drug. Therefore, attention has been focused on that, and looking at the metabolism of warfarin, it's been concluded that genotyping will need to be done for some of the metabolizing enzymes, looking at the consequences of the adverse effect in them. Next slide, please. So, some of, I think there's a slide missing. Sorry. Did we miss 17? Okay, all right, sorry. I apologize. Okay, so some of the things that characterize warfarin is that it has a wide range of dose response. People show various responses. You may give a little dose to an individual and you realize that bleeding will start to occur, whereas other children may take higher doses and there will be no problem. The drug also has narrow therapeutic window, and the high risk of adverse effect like bleeding is so common following the use of warfarin in children. So warfarin is a vitamin K antagonist that exerts its pharmacological effect by two mechanisms. One is by competitively inhibiting the vitamin K epoxy reductase complex, which is called VCOC1. That is what binds to the that's what warfarin binds to. Also, another thing that influences pharmacological response is the rate at which S enantiomer of warfarin, which is the active form of warfarin, because warfarin exists as both R and S enantiomer. The S enantiomer is the active form of warfarin, which is being metabolized majorly by CYP2C9. Now, CYP2C9 and VCOC1 are known to undergo or to show polymorphism, because there will always be variation in the distribution of the two enzymes. So anything that influences them automatically will influence the therapeutic efficacy of the drug. Next slide, please. So this diagram is just taking us through the mechanism of action of warfarin. You know, as you have in the diagram here, you have the two enantiomers, which is the S and the R. Now, once you administer warfarin, if it is in the R, if it's in the S form, which is the active form, before it binds to vitamin K, the enzyme that converts it, reduces vitamin K, definitely part of the warfarin will have been metabolized by CYP2C9. So if an individual is a carrier of fast metabolizing or ultra rapid metabolizing status for CYP2C19, so the amount of warfarin that will be available to bind to this enzyme is going to be less. Therefore, you are unlikely going to have a very good outcome with treatment. And if the individual is a slow metabolizer and you administer the normal therapeutic dose of warfarin, therefore that dose will work normally and there won't be any problem. And if that individual is not a poor metabolizer, it means the normal dose you are administering across all age group would definitely be toxic, because it will be in excess and it will bind to the enzyme, and you will now have a prolonged action which is supposed to have ended over a short period of time. So warfarin occurs as a pair of enantiomers that are differentially metabolized by CYP450 enzyme. The R warfarin is metabolized primarily by CYP1A2 as well as CYP3A4. If there is complete deficiency of CYP2C9, definitely the S enantiomer will be converted to R enantiomer, and it's likely going to be metabolized by those other enzymes. So these enzymes, CYP1A1, CYP1A2, and 3A4, they do not participate in the active metabolism of the active warfarin. They become relevant when there is complete deficiency or absence of 2C19 or 2C9. So our warfarin is metabolized by CYP1A2 as well as CYP3A4, whereas S-warfarin is metabolized primarily by CYP2C9 to 7-hydroxywarfarin. Potential warfarin drug interactions could occur with any of a very wide range of drugs that are metabolized by this enzyme. Also, if you take a concomitant drug that is an inducer of CYP2C9, that inducer will now convert that individual who is a normal metabolizer to now act like a fast metabolizer, because the activity of the enzyme is going to be more, and you have to adjust the dose of the drug in that situation. Next slide, please. Now go to actionable pharmacogenomics in pediatric care. Now, as earlier defined, actionable genotyping is a process where you have to do genotyping before a drug is prescribed. Now, depending on institutions based on the research they have carried out, they have been able to develop protocols for them to know if they need to do genotyping or not before prescribing specific drugs. Now, that is institutional actionable recommendation. Whereas in other institutions, they may not buy the outcome of whatever report or studies people have done. They may be conducting their own studies too. So it doesn't mean that what is obtainable in institution A must necessarily be implemented in institution B. Institution B may decide to do further studies before they can agree to do actionable genotyping. Otherwise, it may not fly. However, there are some conditions that is generally acceptable that genotyping must be done, and I will run you through what FDA had recommended regarding genotyping. Sorry for the pause. So a pharmacogenomic test result may detect a genetic predisposition to an adverse drug reaction, or differentiate between drug responders and non-responders, or it may indicate that a different dose of the drug, or in some cases a different class of drug altogether, is required. That is the basis of pharmacogenomic genotyping. Actionable pharmacogenomics results are those that will alter the choice made by the prescriber, and that will significantly alter the balance of benefit to harm for the individual patient. So every institution that is implementing this makes it necessary that they need to balance the benefit and harm of the drug before it is prescribed. But we all have varied ideas, so it may not be obtainable in all hospitals. Next slide, please. So I have here a few number of genes that genotyping could be done. According to FDA, they are categorized as those that FDA had recommended testing. Even some of these drugs, it comes with a kit where you can actually do bedside testing to know the genotype status of that individual. So FDA had some drugs that they have recommended actionable testing in such treatment. Such of them is an individual carry HLA-B to be prescribed allopurinol as well as oxcarbazepine. Testing is recommended. Genotyping is recommended. CYP2D6, before you prescribe amitriptyline, testing is recommended. I mentioned the other time, NUDT15, before you can prescribe azathioprine, mercaptoprine, and tioguanine, testing is recommended. TPMT, globally, if you have to prescribe azathioprine, mercaptoprine, as well as tioguanine, you must do testing. DPYD, when you need to prescribe capecitabine, which is another anti-cancer drug, testing is recommended. UGT 1A1, if you have to prescribe irinotecan, testing is recommended according to FDA. So it is mandatory that you must do testing before you prescribe those drugs, with testing recommended. However, testing required, meaning to say that you may not, according to FDA, you may not do testing because it is not recommended, but it is required. If the patient can afford, or you feel as a physician you are convinced, then you need to. Such genotype includes CYP2D6, where you need to prescribe eliglostat. HLA-B, if you need to prescribe antiviral drug, Ibacavi, or CFTR, if you need to prescribe Avactor. However, there are some other genotyping where medications is required, such as CYP2D6 requiring tamoxifen, MTRN-R1 requiring prescription of amikacin, CYP2D6 requiring prescription of amitriptyline. In some institutions, they do that. In some institutions, they don't do it. That is why it is called actionable pharmacogenomics. This is not according to FDA, but this is institutional decision to actually recommend the use of such drug if you want or you don't want. Next slide, please. So I want to run you through case reports indicating or suggesting the role of pharmacogenomics in disease conditions and therapy for them. Tangju Liu in 2023 reported a case of a preterm infant with multiple complications, including bronchopulmonary dysplasia, sepsis, intracranial hemorrhage, and hypertension. The infant was treated with various drugs, including dexamethasone and amlodipine, because dexamethasone is required for lung maturation, and amlodipine to treat the hypertension. The infant was diagnosed with neonatal hypertension based on BP measurement exceeding 95 percentile for the age and sex of the patient. Next slide. The possible causes of hypertension, according to the author, included the use of dexamethasone, spironolactone, bronchopulmonary dysplasia. The infant was treated with oral amlodipine to lower his blood pressure. A pharmacogenomic test was performed to evaluate the genetic polymorphism of ABCB1 as well as CYP3A5, which are involved in the metabolism and transport of dexamethasone and amlodipine. Next slide, please. The infant's BP was well controlled after the dose of amlodipine was reduced, according to the pharmacogenomic results. The infant had a stable general condition and was discharged on the 100th day after birth. This case illustrates the importance of regular blood pressure monitoring and etiological investigation in preterm infants with hypertension. Pharmacogenomics can provide useful information for individualized drug therapy and safety in preterm babies. Next slide. So, they conducted pharmacogenomic analysis on the 34th day of life for the baby. Due to the unusual response to medications, a pharmacogenomic gene test via high-throughput sequencing was conducted using the infant's blood sample. The infant's ABCB1 gene associated with the dexamethasone transport is genotyped, and this was found to be GG. And the protein is RS 1045642. This indicates minimal effect on dexamethasone toxicity, dose, and efficacy. Therefore, it was recommended for use of the baby at the regular dose for age and weight. Now, what this is trying to tell us is that after the genotyping, this is a normal metabolizer. This genotype GG serves as a normal transporter for dexamethasone into the cells of into the cell of the baby, as well as pumping of some of the drugs back into the blood circulation. Therefore, there was no need to adjust the dose of dexamethasone following this genotyping. However, this genotype they got, on the other hand, was evil to the transport of amlodipine. We'll go into that. Next slide, please. The ABC1B gene of the antihypertensive drug amlodipine also had a genotype GG, but this genotype GG is serving as a reduced function phenotype, whereas it is a normal phenotype function for dexamethasone. So as it is beneficial to dexamethasone, it is deleterious to amlodipine transport. Meaning to say that the transport of amlodipine in and out of the cell is impaired by this genotype. And what is going to be the consequence of that? It means instead of transporting amlodipine into the cell, you now have accumulation of amlodipine in the systemic circulation of the baby, meaning that the exposure is going to be longer than necessary, which can be deleterious to the baby. Also, the CYP3A5 gene presented as STAR3 genotype, which is linked to slow metabolic phenotype with increased potency, suggesting the need for dosage adjustment. Now, for CYP3A5, this allele is a slow metabolizer. It means the baby is a slow metabolizer of amlodipine. Also, because it's carrying ABCB1 genotype GG, which is also unable to transport amlodipine out of the systemic circulation into the cell of the body, then it means that ABCB will lead to longer exposure of amlodipine, and at the same time, CYP3A5 that is supposed to metabolize amlodipine is ineffective in this baby. So if they have to give the normal dose expected of that baby, then that amlodipine will be very toxic to the baby. Therefore, there is a need to reduce the dose of amlodipine in this baby. So you can imagine if this wasn't done, then of course the baby will suffer a lot of deleterious effect as well as a prolonged action of the drug. Next slide, please. Another report is by Gideon Corrin in Canada in 2005, precisely in April 2005. They reported a full-term LD male infant delivered vaginally who showed intermittent periods of difficulty in breathing, in breastfeeding, and lethargy, which started 7 days after birth. During a well baby pediatric visit on day 11, the pediatrician noted that the baby had regained his birth weight, telling us that the baby is doing fine. On day 12, however, he had gray skin and his milk intake had fallen. He was found dead on day 13. Postmortem analysis showed no anatomical anomalies. Next slide. Blood concentration of morphine was determined when the baby died, and the active metabolite of codeine was the active metabolite, which was found to be 87 nanogram per mil using gas chromatography. The neonates breastfed by mothers receiving codeine typically have morphine serum concentration of no more than 0 to 2.2. But unfortunately, in this baby, the morphine level was 87 nanogram, which is almost 40 times what is recorded in normal babies. The mother had been prescribed a combination preparation of codeine 30 milligram and paracetamol 500 milligram after birth for episiotomy pain. Initially 2 tablets every 12 hours, which was later reduced to half that dose from day 2 because of somnolence and constipation. Next slide. She continued the tablets for 2 weeks. Because of poor neonatal feeding, she stored the milk on day 10, which was later assayed for morphine by gas chromatography. A morphine concentration of 87 nanogram per ml was found also in the stored breast milk. The typical range of milk concentration after repeated maternal codeine is expected to be 1.9 to 20.5, but they recorded 87 at doses of 60 milligram every 6 hours. That was what was reported in previous studies. Genotype analysis was done for cytochrome P450 2D6, which is CYP2D6, the enzyme that metabolizes codeine to morphine. And don't forget that codeine is a prodrug, so the active metabolite is morphine. The enzyme catalyzing the O-demethylation of codeine to morphine. Next slide, please. The mother was heterozygous for a CYP2D6, which is CYP2D6 star 2A allele, with CYP2D6 duplication of star 2, classified as ultra-rapid metabolizer. So the mother was found to be ultra-rapid metabolizer. So the consequence of that is that more codeine is converted to morphine and is excreted into the mother's breast milk. Therefore, breastfeeding the baby, you have a mixture of codeine as well as morphine, but the level of morphine was considered to be too high and it was excreted through the breast milk to the baby, which now became toxic to the baby. So they provided possible pharmacogenomic explanation for the death resulting in that baby. It was stated that the mother, being an ultra-rapid metabolizer, on account of multiple copies of the CYP2D6 gene she possesses, had converted codeine to morphine at an accelerated rate. So a lot of morphine had been produced than required. This can result in dangerously high morphine levels in the breast milk, therefore increasing the risk of opioid toxicity in the infants. Next slide, please. Next slide. So prolonged use or high doses use is a risk factor for the adverse effects. The mother had a prolonged use of codeine because she used codeine for 2 weeks, and it started with an initial high dose. When he started using it 6 hourly, then later it was reduced to 12 hourly. So if you use it 6 hourly at the rate of 30 milligram, so then you're going to have about 240 milligram per day. This can lead to a cumulative increase in morphine concentration, which can be dangerous to the infant. Even in mothers who are normal metabolizers, the amount of codeine shouldn't be as high as that. Several studies have highlighted cases of neonatal morphine toxicity, including respiratory depression and overdose, linked to prolonged codeine use. There have been cases of a child that had tonsillectomy and was prescribed codeine, not knowing that is an ultra-rapid metabolizer that actually led to the death of that child too. So it's not only this case, there are several other cases too. Another slide, please. Next slide. Another explanation is I discussed about the ontology. Apart from the metabolizing enzymes, some of these metabolizing enzymes, their distribution in the early stage of life is not enough to take care of metabolism of certain doses of drugs. So if the drug is too much, because the infant is immature, or in infancy, the metabolizing enzymes are not fully developed, they have not attained adult level, then they're going to have problem in handling the metabolism. So immature hepatic metabolizing enzymes in infants is another risk factor. Infants, especially newborns, have a developing liver, which may not be able to process morphine efficiently. Consequently, the unusual high concentration of morphine in the bloodstream of the reported infant became toxic and resulted in the adverse effect. Assuming the metabolizing enzyme or the baby is older, then definitely the high level of morphine can be handled by the metabolizing enzymes in the baby. So that was another possible explanation. However, I need to mention here that there have been rejoinder to this paper in recent time where other authors are preferring alternative explanation for the death because they did not believe it was the amount of morphine excreted in the breast milk that actually culminated in the death. They suspected foul play. Probably the mother committed homicide on the baby by administering morphine to the baby. And they looked at all other parameters. They realized that the kidney function was normal, and the ability to excrete or eliminate morphine is a determinant of its toxicity. And the baby was reported to have normal kidney function, evidenced by the amount of diaper that the mother changed prior to death. So they have been able to provide, a counter explanation to what Corinne provided. I needed to say this for those who might have read the paper and the current development on it. Next slide, please. So I want to conclude this discussion by letting you know that pharmacogenomics in pediatric care is evolving in the developed countries, but not yet evolved in the developing countries, probably as a result of the challenges it poses, ranging from cost, acceptability, knowledge of service provider, a lot of things that makes it seemingly impossible in this part of the world. And as a physician or a pediatrician, I've not been fortunate to implement this in clinical practice because of policies of the hospital where I work, as well as a lot of costs. People are battling with so many killer diseases, malaria, etc. And looking at the economic situation too, it's not really possible to actually, consider pharmacogenomic implementation as a priority now in Nigeria, looking at the economic challenges we are facing. Pharmacogenomics is a means of achieving precision medicine for children and cut across all disease spectrum, evidenced by my presentation. Unfortunately, the role of pharmacogenomics has been explored in only a few disease cases when you compare to adults. So I thank you for listening, and I thank you for the opportunity given me to make this presentation. Thank you.
Okay, thank you very much, sir. That was a very wonderful and insightful session. Okay, I can see reactions coming in. Thank you very, very much. So, I don't know, how would you like to take questions? Would you want participants to drop their questions in the chat box, or should they simply indicate the given room to speak?
I can take a few ones, and the other ones that may be directed to me via my email, I will surely respond to it. But let me take as many as possible now.
Okay. I think while the call was on, there was a question dropped in the chat box. I can no longer access it now because I had network issues. So if you dropped your question, because I saw a question, I was going to bring attention to it when the talk was over. So you can kindly put your question again. So apart from that person that dropped their question, I believe other participants, if you have question, kindly raise your hands. So the person that dropped a question earlier, please kindly drop it again. So either you raise your hand or you type out your question in the chat box. So we can.
I'm trying to run through the chat box too to see if I can get any.
Oh, okay.
I'm trying to see. But others can bring their question up.
Yes, one hand is currently raised from Imadi.
Okay.
Imadi. Okay, so I think Imadi, I think you can speak. You can unmute yourself and speak. Okay. Okay, I think Imadi wants to drop a question. Imadi, if you can hear me, you can unmute yourself and ask your question. Oh, okay. Oh, she prefers to do that in typing. So while we are waiting for her to drop a question, I think Aruna Jallo is raising his hand, and there's another question from Ari Harans, sorry, in the chat box. So which would you like to take first, sir? The raised hand or the question that is already dropped in the chat box?
Christabel, I've seen a question here
Okay.
by Ari Sharan. The question is, what are the information we get by pharmacogenomic testing in pediatric patients with orphan diseases and their treatment?
Yes, I
Now,
believe this was the question. Yeah.
yes, you see, orphan treatment is a challenge on its own, where you do not have drugs for specific diseases. And I think the whole world is actually pushing towards, clinical trials in children so that drugs can be individualized. But what about diseases that are neglected? Now, medications that are being used for many of these are used as off-label and unlicensed. Off-label and unlicensed use poses the risk of adverse effect. So how would you be able to tell that it is genomic that is playing a role there or not? I don't know if you understand what I'm trying to say. So it is a huge challenge. Those conditions, there are not enough drugs available to them. Even the ones that are being used are not being authorized. Many of them are used as off-label and non-label. So it's a huge challenge, which I don't see pharmacogenomics addressing now, since the drugs have not undergone clinical trial in children, to now say this is the amount of information we have regarding safety of those drugs in children. So, but for now, I don't think I don't think I have information in that field. Let me still run through if I can get
Okay, I
more
think a
questions.
hand is currently raised from Haruna
Okay.
Jallo. Yeah. So Haruna Jallo, you can kindly unmute and ask a question. If you can hear me, Haruna Jallo, you can ask your question.
Okay, while we are waiting for him, there's another question here
Yeah.
by Sheikh Abdurrahman. It says, being about technologies is very informative and interesting session for me. I believe this insight will help. Oh, okay, it wasn't a question.
Okay.
It's a remark. Sorry. So
Yeah, I think
Jalo.
if you scroll down, sir, there's another one. But okay, Jallo is back with us. Aruna Jallo, if you can hear me, you can ask your question. Okay, so if you scroll down, I think there's a question from Imadi. It says, what
Okay.
prospects are available for students in developing countries interested in building a career in pediatric pharmacogenomics vis-a-vis the aforementioned identified challenges?
Okay. I know that we have few, if any, that are pediatric clinical pharmacology in Nigeria. The one or two that I know probably had gotten job in World Health Organization or elsewhere. I can boldly say I'm the only one that is in academia right now. And my goal is to actually propagate this, encourage students, take them on if they need to develop themselves, because I have my international link where I did my training. I still collaborate with them. So if they can reach out to me, doing studies together, mentoring doesn't necessarily require you to be physically there. So we can exchange ideas, emails, and I can provide guidance, and we can chart a course along that route. We are about starting postgraduate studies in Lagos State University College of Medicine in clinical pharmacology. So I want to push for a specialty in pediatric clinical pharmacology where we will solely address problems like this, and people can be well trained and they can start their own course or career along that line. So you should exchange my email with them, let them reach out to me, and we'll have more discussion on the way forward.
Okay. Oh, thank you, sir. That's very wonderful. Thank you very much, sir. Okay, there's another hand raised currently from Daniesta Gabison. So, Daniesta, you can ask your question.
Okay. Good evening, sir. Thanks very much for your time, and thanks for your wealth of knowledge this evening. I think so far, I think delving majorly on the effect of pharmacogenomics in pediatrics and as it affects, is it the pharmacokinetics? I want to ask, what about the pharmacodynamics, like the receptors? I didn't know research on that yet, or because I've just been saying CYP 3A4, the different specific enzymes that what they
Yes.
call it, that
Oh,
metabolize drugs. So,
thank you for the observation. Yes, there are so many of the receptors too, they undergo polymorphism. It's just that I was unable, because of want of time, I didn't really include some aspect of that, you know. So, but definitely the pharmacodynamic too is not left out. But more attention had been given more to pharmacokinetics for now. Many of the publications are more on pharmacokinetics than pharmacodynamic, but certainly it does affect pharmacodynamics too.
Okay. Oh, thank you, sir. So I think there are a number of questions now in the group chat, in the chat box. So I think subsequently you can just drop your questions in the chat box so we can shorten the time. I think the next question I can see here after the last one I read out, I think it says, "Sir, can you give more insights on orphan treatments and drugs?" I think this is kind of related to the other question we had concerning orphans.
Yes. Um, like I said earlier on, um, there are some diseases, especially when it comes to developing countries, that have not been given much attention to because of the cost of drug development, as well as how long it's going to take to develop drugs. So you do not have many drugs available to treat such conditions. Now, these remain orphan conditions. Now, some researchers have been looking at other drugs, which we call drug repurposing, where some existing drugs have been tried for some of the conditions and they found them to be very useful. Because of lack of evidence, this is not a general thing that such drug had to be used for children. However, individual institution may decide that based on evidence we have in our institution, we are comfortable to use this. I'll give you an example. Hemangioma in children. Normally, it should be treated with surgery. If it's in adults, you can use propranolol to treat hemangioma. But in children, some people, they have tried the use of propranolol, which actually led to shrinking of the hemangioma before surgery. Now, propranolol has not been recommended for that. For some people who have done studies, have found the drug to be very useful. And you will never see FDA giving an approval that, okay, start using propranolol to treat hemangioma. But people are doing work in various institutions, and those who are convinced that propranolol can take care of hemangioma, they've been using it. I've used it in my private practice, and I've gotten results too. Now, using it for that, we are using it as off-label and unlicensed drug. Now, we cannot think of genomic study for propranolol use in children for hemangioma simply because we have not gathered enough data for the safety of the drug. So it is a very big issue until we've been able to address drugs that are used for orphan conditions and we have enough evidence through clinical trial studies. Now children are allowed to undergo clinical trials. So if we have enough evidence, maybe there could be an approval for use of such drug, and then we can take it off from there.
Yeah,
I hope
thank
that
you.
I hope that answers the question. I'm trying to see if there are other questions.
Yeah, there are a number of questions. I think the next one after
How
that
does
question.
pharmacogenomics play a significant role in babies administers septrin, cotrimazole for bacterial infection, knowing fully well it causes? Okay, well, the adverse effects being shown um, to cotrimazole, I've not actually explored that, the role of genomic in it. I've not really explored, and I don't think I've done a literature side. But from my experience and my previous publication, the adverse effects that is resulting from this, it's more of um, an allergy that is causing that, which is immunoglobulin mediated. Now, I don't know if the role of pharmacogenomics had come into be to answer that, but I do not have information on that, and I'll be glad to explore and find out if genomics plays a role in it.
Okay. Thank you, sir. I said there was one question above that question from Harry Aran. It
Okay.
says, one last question, sir.
Yeah.
Does pharmacogenomics have any role in diagnosis? Thank you for the opportunity.
Oh, sure. You see, there are some biomarkers that are used to diagnose some conditions. And those biomarkers too are being influenced. Don't forget that the production of those biomarkers is as a result of one enzyme converting one molecule in the body to another. So if there are problems with those metabolizing enzyme by genotyping, you can actually tell if the level of biomarker you are getting is as a result of the disease or as a result of inefficiency of the enzyme that is producing those biomarkers. And there are so many laboratories now that are actually using that for diagnosis of some conditions, and we have them many in Nigeria, like SynLab. If you suspect any disease condition that you feel is genetic related, and you can use drug to target that gene also, why not? But the truth is, these are not things that are easy to come by in Nigeria because of cost of treatment.
Okay. Thank you, sir. So, sir, would you want to continue with the question, or should the further questions be sent to your email? Because currently we are.
I will appreciate if it is sent to me. I had to excuse myself to make sure I
Okay.
didn't miss this, but I'm glad to answer more questions. Let them
Okay.
send to my email. I will
Okay.
attend to it.
Okay.
And
Thank
if
you very much.
possible, if they can exchange phone number too, I can put a call through if necessary to individuals.
Oh, wow, that's very interesting, sir. Thank you. Thank you
My
so
pleasure.
much for being
Thank you.
available.
It's my pleasure, and I wish you more happy deliberation in subsequent webinars.
Thank you, sir. It was an honor to have you here. Thank you
My
very much.
pleasure.
Thank you so much, sir. Thank you
you.
so much, sir.
Bye.
All right.
Okay. So I am very excited, not just because today's session was so insightful, but because we have come to the end. It's a wrap, and it has been very beautiful. Okay, I can see someone asking for the survey link. Pinned, but I'll send it in again. So honestly, I'm overwhelmed with happiness at this point. So thank you, everyone for joining us. So I think I would do well to hand over to Destiny now to take us further on what is next. Thank you.
Yeah, thank you so much, Christabel, and thank you so much, everyone that joined today. Finally, we've come to the end of our session, our webinar series, and I'm going to plead with you again. Please do ensure you fill the post-webinar survey. It helps us to improve on giving more of these sessions to you so that we are able to do better in subsequent deliveries. So please do well to fill the form. And like I said earlier, it's completely voluntary. And the slides from some of the sessions, I know we've not had the slides from the third session and the slide from the fifth session. So all of those will be put together. An email will be sent to each and every one of us that did registered, containing all of the recordings and the slides. So if you've missed any of the slides for any of the days, be rest assured that those will be sent to your email. So you have complete access to any of them. And do well, feel free to reach out to any of us in Pharmagenosphere, in Midodrix, and Pharmacy Graduates Association of Pakistan, or Transcend Consulting. At any time, you can reach through to us via LinkedIn or even through the WhatsApp group. So once again, thank you.
There are some hands raised, Destiny. The hands have been very persistent, so I don't know if we could listen to.
Okay. Yeah. Lukmal, please, you can unmute and ask a question if you do have a question. Okay.
Yes.
Maybe that must have been like a mistake or something.
Okay, thank you very much, Destiny. So for those saying they want the email and everything, all the resources you need will definitely be sent. I can see Anonymous saying she feels like crying. Well, I can say I think Ake Abbas is saying I feel like crying, but I feel like crying too, tears of joy. I'm sure Destiny feels like crying also.
And